This is Vamsidhar Velcheti. I'm a medical oncologist specializing in lung cancer at the Cleveland Clinic. And I'm here to talk about biomarkers for immunotherapy. And as all of you know, over the past several years, we've had an explosion in treatment with immunotherapy, and treatment with immunotherapy, especially the PD1, PDL1 inhibitors, have changed the landscape of treatment for lung cancer and several other cancers as well. But the biggest challenge has been to identify patients who would benefit most from these immunotherapy treatments. As of now, the only FDA-approved biomarker for treatment selection has been a PDL1 assay by a DACO22C3. That's the only FDA-approved companion diagnostic. And there have been several other PDL1 biomarker assays that are also being used routinely in the clinic to stratify or identify patients who would benefit most from a PD1 or PDL1 inhibitor. However, these biomarkers are mainly what I call enrichment biomarkers. What I mean by that is patients who do not have a PDL1 expression also could potentially benefit from these drugs, and especially for patients who have lung cancer who have somewhat limited treatment options, when we have a biomarker that is not as good for selecting patients who would respond from PD1, PDL1 inhibitor, it is really important to consider that even patients who do not have a biomarker expression could potentially benefit from these treatments. So we need to do better in trying to identify patients who would benefit from these treatments. There are several newer strategies being looked at in terms of biomarkers for immunotherapy, and one of the most promising biomarker is tumor mutation burden. And this is essentially looking at the amount of genomic or genetic mutation load in a particular tumor sample. And patients who have a higher genetic mutation burden tend to have tumors that have more inflammation, or when you have a higher load of genetic mutations in the tumor, the immune system recognizes the tumors better and are able to respond to immunotherapy treatments. However, these strategies have not yet been FDA approved. There are a lot of clinical trials and a lot of data that has been presented in the recent meetings at ESMO and most recently in the AACR annual meeting. So these strategies appear to be complementing the PDL1 expression as a biomarker. However, these need to be further validated in prospective clinical trials. There are a lot of clinical trials ongoing looking at circulating tumor DNA-based tumor mutation burden, and I'm very certain that in the next year or so we will be seeing the results of these clinical trials, and we will have better biomarkers for predicting and identifying patients who would benefit from PD1 therapy. And what is also very interesting is going forward, there are a lot of clinical trials looking at combination immunotherapy approaches. So how do we select patients for those combination approaches versus a single agent immunotherapy? So these are challenges for the future. We will be most certainly hearing more data and information about biomarkers and how to incorporate these biomarkers to identify patients for combination immunotherapy versus single agent immunotherapy. And it's an exciting time in oncology, and especially for immunotherapy and for patients. There are a lot of options and opportunities to improve chances for success and long-term success.